All right, we are going to cover some respiration and artificial ventilation, chapter 10 of your EMT books. Topics we're going to cover is physiology and the pathophysiology, respiration itself, positive pressure ventilation, oxygen therapies, special considerations, and then assisting with advanced airways. Physiology and pathophysiology. So physiology is how like ventilation, respiration, all of that works. And then the pathophysiology is diseases that may affect how the breathing, ventilation, everything works. So ventilation itself is the process of moving air in, which is your inhalation, and then out, where you exhale. Inhalation is active. What it means by active is the actual like movement of the diaphragm. The diaphragm contracts, it pulls down. And when it pulls down, the pressure inside the lungs becomes less. So because there's less volume in there. So more air gets moved into the lung space. So you're not actually like sucking in air. The diaphragm is squeezing and causing air to get moved to fill the space, to fill the void of where the diaphragm contracted, if that makes sense. So it is an active process. The diaphragm has to contract. And then negative pressure pulls air into the lungs. Exhalation is a passive process. The diaphragm will relax. So now it's going back and filling that space that it once took up, which means the pressure becomes more increased. And the air has to go somewhere, so it goes out. Tidal volume is the amount of air moved in one breath. Minute volume is the amount of air moved into and out of the lungs in 1 minute. Ventilation is designed to move air to and from the alveoli. So alveoli, you'll remember from your anatomy and physiology. They're like little balloons inside the lungs. So ventilation is the movement of air to and from the alveoli. Not all the air that we breathe will reach the alveoli. Think about like the size of your lungs, and then that negative pressure, all that air has to kind of sit in the void or in the spaces. So as it says there, some air occupies dead space. It is impossible to get all of the air out because air fills the entire room. Air fills your lungs. It fills up all the spaces. Alveolar ventilation refers to the actual air that moves to the alveoli. So there's ventilation and then there's alveolar ventilation. It can be altered by changes in your rate or your volume. So you're breathing faster, more is going to reach the alveoli. You're breathing more deep, more is more likely going to reach. So it really depends on the tidal volume. Alveoli form the ends of the bronchial tubes. They're these little balloons, these little sacs. They're inflated, and then they get ventilated as air moves in and out. The capillaries surround the alveoli, and it brings blood close to the sacs. The oxygen will then move from the lungs into the blood. So carbon dioxide moves out of the blood and back into the alveoli, where we then exhale it. Diffusion is the movement of gases from an area of high concentration to an area of low concentration. That's what I'm saying. Like in your bedroom, there's not pockets of like no air. It has filled your entire room. Diffusion is, someone gave me an example of like a pizza, or I like bacon. I like the smell of bacon. And you don't have to be right next to the bacon to smell it. That smell has been diffused or carried out throughout everything. It fills all the spaces in the room. So think of that as diffusion. Diffusion is movement of gases from an area of high concentration to an area of low concentration. Right next to the bacon is that high concentration, and then it kind of just spreads everywhere else. In your alveoli, there's a bunch of oxygen waiting to be moved, and there's no oxygen on the other side. So it moves, it passes freely into the area where there's no oxygen. And then the carbon dioxide wants to get back to the other direction because it's on that side of the alveoli. So it wants to move to the area where there is none. It wants to spread its love. In order for you to basically breathe, the pulmonary and cellular respiration have to function together. This is why we call it cardiopulmonary, because it's the heart and the lungs. There's also a ventilation and perfusion, so breathing and blood flow match. When one of the system fails, the entire system will fail. I highly stress airway, breathing, circulation. Everybody dies with airway, breathing, circulation. If there's an airway problem, it'll affect your ventilation, which will then in turn affect your cardiac. If there is a breathing problem, you stop breathing, but your airway is open, you're going to end up dying. If there is a heart problem and your heart stops, you're going to end up dying. So airway, breathing, circulation, one of those, if there is a failure. If you have a patient that's bled out, they don't have any blood, they can be breathing all they want, but it's not going to last long. The blood that supplies the oxygen and the carbon dioxide exchange, if it's not there, it's not going to work. Mechanical failures of the cardiopulmonary system, you need to have your chest cavity whole. It needs to be able to support the movement of the lungs without allowing the air to escape. If there is air, and we'll talk about this in trauma, you're gonna learn about hemothoraxes and pneumothoraxes. And if there is air outside the lungs in the chest cavity, it's hard for your lungs to be able to equalize the pressure and create that negative and then the positive and then the negative every time it breathes. You can see here just a few of the other things that may cause changes in the physiology, so the pathophysiology. There's airway problems like bronchoconstriction, because you're asthmatics. Interrupted gas exchange can impair the ability to fuse it. So if you are at high altitudes, low oxygen levels are not getting into the body. So high altitude, this last year, so it's 2021 now, this last year in 2020, I took a trip to South America, and I don't know, some sort of belief in me was like, hey, I live in Alaska, there's a lot of mountains, I'll be all right. But I did go to an area that was 13,000 feet. 13,000 feet is quite high. And man, I had to suck some air in because it is so thin that it took much deeper breaths and much more fast to be able to get the same amount of oxygen I was used to getting. Circulation issues prevent blood from carrying enough oxygen. So airway, breathing, circulation. The first one being the airway, second one being the breathing. Here's the circulation. If there's a problem with any of those three, it'll make ventilation difficult or impossible. Respirations. Before you go and you start counting respirations, before you get to that process, the first thing you need to recognize is, are they breathing and is it adequate? You can check this by looking at the color of the skin, by like an overall appearance of, does it look deep? Does it look shallow? Does it look too fast? Does it look too slow? And then their mentation. Hypoxia, one of the first things that goes, one of the first signs that there is a problem with oxygenation is their mental status. So hypoxia, so hypoxia is low level of oxygen function, and then hyper being high, capnia is a high level of carbon dioxide. If they're not breathing out, then there's going to be an abundance of carbon dioxide inside. And you want to assess this by evaluating the entire cardiopulmonary system. Talked a little bit about if one part of the system fails, the body will try to compensate before it completely fails. So there's chemoreceptors. So like speed, that's the chemo. Speed receptors, well, it's a receptor. It's like transmission. So it transmits the rest of the body to start to breathe faster. So it's like, hey, I'm not getting enough oxygen. I'm at 13,000 feet. I didn't have to tell my body to breathe faster. It did it on its own to help make it feel better. So respiratory rate increases, your heart rate will increase, the blood vessels constrict to get a little bit more speed in the blood flow, to get more pressure to be able to push the carbon dioxide out, and that desire to pull more oxygen in. Respiratory distress, you have to know these three. So the respiratory distress versus respiratory failure, you have to know the difference between those two. And then the last one is respiratory arrest. So respiratory distress, compensation is working. I was in distress. I'm walking at 13,000 feet. I knew where I was, who I was. My skin color was fine. I probably have good SpO2. I was just in a little distress. A little bit of like oxygen, a little bit of rest. When I sat down and just relaxed, it was better. It was still hard to work. It was still hard, like working to breathe. The key here for respiratory failure is that compensation's not working. Something's not working. Mentation is always the first to go. They may get a headache. They may feel a little like fuzzy or lightheaded. That means that their respirations are not, their ventilation's not adequate. So metabolic needs of the body are not met. There's not a breakdown. There's not an oxygen, carbon dioxide match. And then respiratory failure ends up being respiratory arrest, where they are not breathing, or they're not breathing enough, like 4 times a minute. They've completely lost the ability to breathe on their own, and they're going to need outside help. Respiratory failure, they need a mask. They need a lot more oxygen being applied to them. So respiratory distress, maybe they just need a nasal cannula. They just need a little bit of coaching or some rest, having them sit. Respiratory failure, they're going to need a non-rebreather mask. They're going to need a lot more oxygen. And then respiratory failure leading to arrest is going to be a BVM. You're going to have to bag them. CPAP only works in the respiratory distress. The respiratory failure, once they start having problems with their mentation, they're not going to be able to hold the CPAP mask on. And then it will turn into arrest, and you'll learn later that CPAP does not work if they're not breathing. So inadequate breathing occurs when the challenge is too great. Your body is not able to compensate anymore. Either they're breathing too fast and it's not adequate, they're breathing too deep and they start to like get fatigued. They aren't breathing deep enough, or they're breathing too slow. You have to be able to recognize these. You have to be able to recognize any alteration in mental status. So when you walk up to them, you guys know your AVPU, and they're alert and they're looking at you. They can either be in distress or no respiratory issues at all. If they are in some sort of like panic, or you have to say, hey, how you doing? And then they look at you, there may be some issues to where it's getting from adequate to inadequate. So recognizing why we use the AVPU, it determines the quick down and dirty mentation. It does get a little bit more in depth, a lot more in depth when you use the GCS, but a good quick down and dirty is your AVPU. All right, patient assessment for respirations. Are they breathing? Is there movement in the chest? Is there air going in and out? And then determine if it is adequate. Adequate breathing is, you can see the chest rise, you can hear air leaving the nose, the mouth. There's a typical coloration in the skin. We want warm, pink, and dry. If it is blue, they're not getting enough oxygen. And then you can, once you get the first one, so are they breathing? Is it adequate? Oh, now I'm going to get the rate, the rhythm, the quality, and the depth. So rate is your speed. You're gonna count, and then get a rate respirations per minute. The rhythm, is it regular? Is it like there's a couple different types of breathing. So they have one called like Cheyne-Stokes, which is like breathing fast, like like different patterns. So is the rhythm a pattern? Is it regular? Is it irregular, like in and out, and then pausing, and then out, 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 in, like weird? You'll see that with like seizures. They'll try to breathe, but when their diaphragm is seizing, they're going to breathe erratically. Quality, that's going to be your, can you hear it? Is it raspy? Are they coughing? Do you hear stridor, which is like a high-pitched whistle? And then the depth, are they breathing super shallow? Or are they breathing very deep? With some diabetics, they'll get this really deep breath in. And that's how they're trying to breathe off a bunch of their sugar because they're having a diabetic emergency. Inadequate breathing, very first one on the list. Mental status is altered. That is super key for you guys' tests, for your guys' quizzes. If it is any alteration to their mental status, they're difficult to arouse, they're confused, it takes you touching them to get them to look at you, any of those, it is inadequate, which means you're going to have to put some sort of non-rebreather mask on, BVM. You need to consider airway and breathing interventions. Chest movements could be absent or very uneven. There could be trauma to the chest that causes it to be uneven. In children, their pulse rate will slow down. So you have a child with a heart rate in the 60s. That's a great heart rate for an adult. That is very poor for children. Children should be at like 100 or higher. Just think 100. Breathing movements are limited to the abdomen, so they're not able to use their chest wall. They're not able to use their chest muscles. Maybe there's damage to it. Breath sounds are diminished or absent. They could have a punctured lung. They could be full of fluid. They could have a lot of bronchospasms, so they're having an asthma attack, maybe an allergic reaction. And then the wheezing, gurgling, there could be problems with stuff in the airway or airway blockage. More signs of inadequate. The rate of breathing is too fast or too slow. It's too shallow or too deep. Coloration in the skin. So cyanosis is the bluing. If they're unable to speak, so there's like one-word dyspnea. There's two-word dyspnea. Dyspnea is like the difficulty in like breathing. So if you're trying to assess how I can breathe and I'm going, hi, can't breathe, it is hurting, that is two-word dyspnea. I can only get about 2 words in before I'm completely out of breath. Hypoxia is insufficient supply of oxygen. Common causes, it could be from a fire, from smoke inhalation. It could be from emphysema, and you're going to learn more about that. It could be from too much heroin, and they are having the inability to use those chemoreceptors. They're not able to increase their speed, and they end up going slower and slower and slower. It could be from a heart attack, a stroke, an embolism is like a clot. So hypoxia, you're going to find someone with altered mental status, and it could include signs of cyanosis. So address the cause. If they're in a smoky environment, get them out of the smoke. Can't do a whole lot for emphysema. That is a chronic disorder you're going to learn more about. Patient overdoses on a drug, get the needle out of their arm, get Narcan ready. You need to address the cause and administer oxygen. Let's see. Artificial ventilation, this is going to be for your uncompensating, unable to protect their own airway. It's going to be inadequate breathing. You will start off with no oxygen, just get their ventilations going because air is going to be adequate enough. And then putting supplemental oxygen on. We want to keep their SpO2 above 94%. You need to do this quickly. If you do not see adequate breathing, you're going to check their airway, you're going to check their breathing. If they're not breathing, you're going to breathe for them. It's better to be too aggressive than not aggressive enough, and they end up not having enough oxygen throughout their body and dying. Positive pressure ventilation. This goes with your bag valve mask. So we talked a little bit about negative pressure when you breathe in and positive pressure breathing out. So we call the artificial ventilation positive pressure because it's a little bag attached to a mask, and you squeeze the bag, and the space inside the bag becomes smaller and smaller, which increases the pressure. The pressure has to go somewhere, so it goes into the lungs. That is the positive pressure ventilation. We use that with a bag valve mask, and you'll see that later with CPAP. Positive pressure relies on the force that's actually pushing it in. So instead of the negative pressure from the diaphragm, it's an actual force that pushes the air in. There are some side effects to it because it is using positive pressure. That means the space inside the lungs is getting higher in pressure, which is putting stress and pressure on the heart and blood vessels. Since there's only a limited amount of capacity in the lungs, when they get completely full, the air could go down the esophagus and go into the stomach. And if that happens, the air will fill the stomach and food will have to go somewhere. So sometimes it comes back up. It could be that you are hyperventilating, so too much, and it blows off too much carbon dioxide. The carbon dioxide's leaving too quickly. And your body starts to try to hold on to that carbon dioxide, and then it starts to vasoconstrict. So it actually increases blood pressure throughout the rest of the body, which we want some increase of blood pressure when they're altered, but we don't want a significant increase because that pressure then relates back to the brain. It relates to other things that need to function. So the brain's already being starved of oxygen, and then you constrict the blood vessels around the brain, and it's going to cause even more altered. There's 3 methods to doing positive pressure. That's the mouth to mask. I highly suggest not doing mouth to mouth. Mouth to mouth is gross. You don't know what the person has. I will only do mouth to mouth to like a family member or like a baby or a small child. I do not want to do mouth to mouth on a stranger. I do carry a little pocket mask on my backpack if I have my backpack with me. Then you have the 2 rescuer bag valve mask and the 1 rescuer. If somebody is vomiting, you're going to have to tilt them to the side and clear that airway out first before you push air into the mouth, because you don't want to put that vomit into the lungs. Another reason I don't do mouth to mouth, because of the vomit. Ensure adequate ventilations. You want to see the chest rise and fall. Now think about how you breathe. Your lungs fill up and your chest moves a little bit. Try to emulate that. We don't need to see their chest expand all the way out to where it can't move anymore. That's not how we breathe each time. So just until very minimal chest rise. The second you see the chest rise, that means the lungs have filled up. They filled up enough that the ribs are starting to move. You don't have to keep going, keep going. Ensure the rate of ventilation. So knowing what your values are for adults, pediatrics, and infants. Every 5 seconds, 5 to 6 seconds is great for an adult. It's about 10 to 12 breaths per minute. If you think about how much you breathe, because this is artificial ventilation, it can be a little bit slower. We typically breathe 14, 16 times a minute. But since we're artificially ventilating and we're putting a lot more in, we don't want, and we're doing that positive pressure, we might be putting pressure on the heart and the blood vessels. We don't have to go nearly as fast. So 10 to 12 breaths per minute is going to be sufficient. Do not use mouth-to-mouth ventilation. There's vomit, there's herpes, there's all sorts of nastiness. Gross. Do use a barrier device. They have them on keychains, in all the AEDs, in stores or in public areas. There's going to be a ventilation block, a barrier in the there should be. It comes usually with the pads. When ventilating a patient who's breathing too quickly, so we will actually slow people down. The biggest thing is explaining the procedure to the patient. You have to be able to coach them. You don't want them to freak out and panic. There may be times where you have to almost force the air in at a much slower rate to try to calm them down. You need to adjust the rate to get slower and slower. So you can start kind of rapid every like 3 seconds, and then pretty soon every 4 seconds, and then get down to the 5 or 6 seconds, and coaching them the whole time. I'll try to tell them to like breathe in and like hold that breath as long as you can. Try to coach them out. That's the biggest thing, is explaining and trying to calm them down. Let's see. You're going to add ventilation in between the patient's own breath when you need to breathe for them because they're breathing too slow. You want to increase the rate to about 12 times per minute. So if they're breathing at 30, you're going to try to decrease it to about 12 times per minute. And if they're breathing under 8 to 10, you need to bring it up to about 12 times per minute. Opening the airway, you need to look, listen, and feel. You need to look in there to see if you see any vomitus, any blood, any teeth, any food, and you need to clear the airway. You're not going to put your finger in. You're not going to do a blind finger sweep. If you can see liquid, you need to suction it out. When it talks about positioning the airway, you need it neutral, which is not side to side. Like you need it like midline, and then you can either do a jaw thrust or you can do a head tilt. So sniffing position is optimal. That head tilt chin lift is the more optimal position. It is a lot easier on an adult. On a child, you actually have to like lift the shoulders up. So putting a pad behind their shoulders to allow space for their giant head. Obese patients, there's a lot of weight on their chest. So bringing them to a like 45-degree angle will allow some of that weight to kind of go down towards their belly instead of on top of their chest. It's a lot more difficult with your obese patients because there is a lot more fatty tissue. They are going to be heavier and harder to support and move. But the idea is to keep the airway open by positioning the head in the middle and then opening up the airway with either a head tilt chin lift or a jaw thrust maneuver. But remember that obese patients may have a lot of weight that you're going to have to push off of. So the force that you push in is going to have to fill those lungs, and those lungs are going to have a fight to get the ribs to move. So be aware that you're going to be increasing a lot of pressure, and it could actually do more damage. We talked about pressure on the heart. We talked about vasoconstriction. So putting them at that angle is going to decrease some of that outside pressure on their ribs. Sealing the mask, you want to make sure that you seal all the way around. This is why two-person ventilation is actually preferred, because one person can concentrate with the EC clamp with both hands and really bring that face up to the mask. And then the other person can breathe. And when I say bring the face to the mask, you're not shoving the mask down on the person's face. You're putting them together, you're meshing them together, and then you're bringing the chin up into the mask. So you don't want to push down. You always want to bring that face up. You want to try to get that jaw, bring that chin, get that bottom jaw up into the mask, and sealing with the other hand over the nose. Sometimes people have big beards. Some people have like trauma to the face. Dentures need to be left in place unless they're affecting the airway, unless they're moving all around and they're in the way. You should leave dentures in place because it's a lot easier to ventilate when you don't have giant loose flaps in the way. And I know it kind of sounds silly, but it's totally like legit. You don't want big floppy lips. You want the teeth to be able to kind of take up a little bit of that, and it gives you a little bit more foundation to work with. So using a team to ventilate and using an airway adjunct are great ways to help you create a better seal. So having that two-person ventilation, and then the airway adjunct helps pull that jaw forward, helps move that tongue out of the way, to where you still have to do the pulling the face to the mask, but it's going to make it a lot easier on your hands, and you can do it for a lot longer. Mouth to mask ventilation, they'll have like a one-way where air will go in, but stuff can't come out, and that's to protect you. So make sure you have it on the right direction. Here is a mask. You can see here, this is actually like a one-way valve on the top. It is anatomically shaped. You see where it says nose? It will be anatomically shaped, like a little triangle at the top of the nose, and then round or a flat piece where the chin goes. So if you're doing mouth to mask for someone without a spinal injury, be at the top of the head, the sniffing position, so opening up the airway, head tilt, chin lift, thumbs over the top of the mask. So you're going to be up above them, like you're looking down at their face, you're directly above them. You're going to put your thumbs over the top of the mask and your index fingers on the bottom of the mask and like underneath that jaw. Bring that jaw up. You need to squeeze the mask with your thumbs, give breaths in the one-way valve, and then watch for that chest raise. So while you're breathing, you need to point your eyes up to that chest. The second it moves, you're good to go. So right here. So he's got fingers on that jaw. He's able to see. So he's able to see here, that line of sight. He's bringing the jaw up to the mask. And this one here actually has the ability to have an oxygen supply to it. Not all masks will have that. There is a one-way valve, so air can go through, but it can't come out. That way you don't have vomit and other things. I don't use the strap around the head. I have like a little pocket one. It's basically just like a sheet of plastic with a little one-way valve. Mouth and mask for a patient without a spine injury. Did that already. With a spine injury. Here we go. So the difference here is lift at the angle of the jaw, but do not tilt the head backwards. Everything else is the same. You're still going to use your thumbs to squeeze the mask. You're still going to give breaths through the one way and then be able to look for ventilations. Bag valve masks. So instead of using mouth to mask, it is a bag, there's a valve, and it has a mask attached to it. They do have different sizes, adult, child, and infant. They do self-refill, so it's like a little rubber pouch, rubber balloon, and you squeeze it, and then when you let go of it, it fills back up. So here we go. Adult, child, and infant, because we do not want to explode lungs. So that's why there are different sizes. The masks actually go down in size as well. So the difference here, and you guys will learn about like number breather masks, and the BVM is a little bit different. So this bag here does not have to be full for this to work. There is air in here. So air in here, and then this will fill up with O2 once this is hooked up. So 15 liters per minute will go into here. It fills this up. And then once you start using oxygen, this will become O2. So we can actually give them 100% oxygen. There we go. Beautiful, right? So it's not like the non-rebreather mask because there is space in here. If this is empty, it doesn't mean that this is empty. There's still stuff available in here that you're going to breathe for. That's the key with why this bag does not need to inflate. So when air is squeezed, oxygen is delivered to the patient. When it's released, it passively, like the patient will passively exhale or expire because the pressure is no longer being forced into the lungs, so then it will relax. When it says here, the patient exhale, oxygen enters the reservoir, that's that reservoir bag. Because you're not pushing air in, it has time to fill that reservoir bag up. Two-person BVM, the very same position. You want their head in the same position as the other ventilations. You need to select the correct size of BVM. This is where you're going to get the EC clamp. It's better with two people. There should be a picture right here. So we'll go back to those slides so you guys can read them, and then take a chance for you to pause it if you need to. So we've got the two thumb here. So it's still going to make some sort of like EC. When you're by yourself, it's like a single EC. This one's like a double. So go. You can see there's like an E and a C. There you go, EC. It's best because he's got pressure on both sides. So one thumb, two thumb, but then he's bringing this jaw up to the mask. So they're not pushing this whole thing down. They're bringing that jaw up to the mask. So we'll go back to these slides so you can read them. key on this one without tilting the head. Run one rescue ventilation. There's the C. Doesn't talk about the E, but if the chest does not rise and fall during BVM, you need to reposition the head because there's either a problem with the airway, breathing, circulation. You're going to check for escape around the mask. You're going to look for an obstruction. Maybe there's something in the way. Maybe you're called for a choking patient. Can continue to try to use the bag valve mask if you believe that there is a obstruction during CPR. You can continue every time you go to breathe for them, you look, see if there's anything in there that you can actually grab, and you may need to resuction. BVM will be used during CPR. It is preferred to use a pocket mask with supplemental oxygen over BVM because you're going to have a better seal. You're less likely to put air into the stomach, and you're more likely to have a better seal. Ventilation of a stoma breather. A stoma is basically a surgical hole in the throat, and you'll see this with people that are on ventilators, people that have had like mouth cancers. You need to make sure that the airway is clear. So instead of the airway being their mouth, the airway is now a hole in their throat. So there might be some mucus, there might be some vomit or blood or something, some sort of secretions. You need to be able to suction that out. You can use a pediatric size mask to go over the stoma, and some of them actually have ends on them that will attach to the BVM. There we go. There we go. Adults should be ventilated 10 to 12 times per minute, so every 5 to 6 seconds. Children will be ventilated 12 to 20 times per minute. And actually in CPR now, they're looking at every 2 to 3 seconds instead of 3 to 5 seconds. So with kids, go to every 3 seconds. With adults, every 5 seconds. You guys will learn about end tidal CO2, and you will base these values off of the end tidal. So you might have to go with the higher end. Maybe you have to go to 12 times per minute. Maybe with kids, you need to slow down to 12 times per minute. So too fast can cause hyperventilation and vasoconstriction. So remember, there is a reason we don't want to hyperventilate or hypoventilate. When you are, you don't have to like squeeze the entire bag aggressively. It should take over 1 whole second. Remember, we don't breathe. We don't breathe super quick like that. Nice and slow, over 1 second. Allow the lungs to fill. You're going to stop. You're going to allow it to decrease. So 1, 1,000, 2, 3, 4, 5, 1, 1,000, 2. So that 1, 1,000 you squeeze, then you let go for 2, 3, 4, 5. Squeeze 1, 2, 3, 4. Squeeze. You see how that works? So over 1 second, you're going to squeeze, you're going to let go, and you're going to wait for the rest of the time to go through. So automatic transport ventilator. If these people need to be ventilated and they have a machine, that's essentially what that is. You might have to transport somebody that is on a ventilator. There's different settings. So there's breaths per minute. There's like how fast that's that 1, 2, 3, 4. So, and then the volume. So little kids are going to be a lot smaller than adults. Oxygen therapy. Oxygen is a drug. We are not meant to breathe 100% oxygen. The reason our atmosphere is 21% oxygen is because that's what our body needs. Our body also needs the other things that are in air. Oxygen and air are different. Air is the combination of nitrogen, oxygen, and carbon dioxide and other gases. Oxygen is oxygen. Prolonged use of 100% oxygen can be very damaging. It can cause damage to the heart. It can cause damage to the brain. It can cause damage to different areas of the body. So we want to go at an SpO2 of 94% or higher, and we want to do an end tidal of 35 to 45, and you guys will learn more about that. You need to always, always, always ventilate cardiac arrest patients, and don't withhold oxygen to anybody that's in respiratory distress. Most systems contain a cylinder. There's a pressure regulator and some sort of delivery device. You can use other devices like a BVM or a pocket mask if you hook it directly to the source that's providing the oxygen. Different sizes of oxygen cylinders. These cylinders are going to be the most common in like the back of an ambulance or attached to a gurney. There's all oxygen is going to be green and gray, green and white. There's different ways that you can determine that it is oxygen. So here is a large cylinder. You get a nice fancy lift because those things can be kind of heavy. And oxygen needs to be secured. There is a lot of pressure. There's a lot of pressure in that because 350 liters of oxygen in a little teeny tiny tank. The little teeny tank is only the size of about 2-liter bottles, but there's 350 liters of oxygen in it, so it is highly pressurized. So cylinder safety, you need to pay attention to where it's sitting. Never stand them up on their own without having a hand on it. If you just let them stand there freely, they can fall over and break the end of the cylinder right off. There's a lot of pressure. It could become quite the rocket. It talks about non-ferrous wrenches, and this is because of a spark. Oxygen's not flammable, but oxygen feeds fire. So having a spark is not going to ignite the oxygen, but having a spark in another area, or maybe the spark sparks against some cloth and the oxygen's there to feed that fire, that's when you're going to have a problem. Let's see, we test our cylinders. Never let it fall against an object, never let it drop. This is key here, never let oxygen cylinder standing upright without it being secured. And then don't allow any smoking around the oxygen equipment. And that's, again, because there could be an ignition of a fire with the extra oxygen in the room. Never use grease, oil, or fat-based soaps on the devices. This can actually clog up and block the movement of air. Don't ever drag it. You could damage the cylinder. So, other thing that I want to show you is, so it's either green and gray. So there's green, and then there's like green and gray. So the one we saw in the ambulance before was completely green. This one's here green and with gray. It says oxygen on it, and it's got what is called the pin indexing system, which is right here. I don't know why I just did that. So pin indexing system. It'll have one hole where the oxygen will go into, and then it will have like an indentation here and an indentation here. Other regulators, so this regulator here, you can see a pin, and then it will have a hole where the oxygen actually goes into, and it will line perfectly up with the pin indexing system. So I know this is oxygen because it says oxygen. It's green or green and gray in color, and the pin indexing system. That is key. When you guys do your oxygen station, and when you have to prove that you know how to put oxygen together, you have to determine that you know it's oxygen. It's not acetylene, it's not nitrous oxide, it's not other things. So E-size, it's a yoke assembly. We saw that here on this one. For the larger ones, it's actually threaded onto top. Let's see. Before you connect the regulator, you want to open it up slightly. So you want to open, this is the key end here, and it will kind of release a bunch of pressure because you don't want that dust going into the regulator. Some information here about different tanks. It really depends on where you're going to be working. At the hospital, you're going to have a main source or a main oxygen delivery system. There might be some tanks here and there. On the ambulances, usually there's a small tank used on the gurney, where the larger tank is the main oxygen for the rest of the ambulance. So here, this one will be pressure compensated flow meter. You'll see this sometimes in the back of an ambulance, or you'll see this in the hospital. And this here is a constant flow selector. So the constant flow here, you can increase it. This here is the pressure increases, it will continue keeping the same flow, or decreases. So you can't see it, but the pin indexing system is like right here. So there'll be the 2 pins and then the 1 air opening. This here secures it. It actually like squeezes onto the top of the bottle. This is high pressure delivery system. There's a large threaded hose that will connect to here, and it kind of bypasses this. This is the meter. This is, you turn this to deliver the flow rate. So let's draw this up here. So you've got your oxygen tank goes here. There's my little pin indexing system. You're going to twist this to tighten it, so this is nice and secured. You're going to put your tubing to go to your patient here, and then you're going to rotate this to whatever you need. So nasal cannula will be 2 to 6 liters per minute. Non-rebreather mask will be 10 to 15, and a BVM will be 10 to 15 liters per minute. Now, when you need something higher, you need a CPAP or something. This is where the other device comes into play. So you've got your big tube, you're going to screw onto here, and then it only focuses on this. It no longer looks at the rate. It is a high pressure, so this is where your CPAP machine will go. Or other devices. It could go to a vent machine, it could go to other oxygen delivery systems. Humidifiers can be connected to the flow meter. It basically makes it to where the oxygen that's being delivered is going to be more humidified. It really helps when you have like a hypothermic patient. You can have heated and humidified air, because that humidified will actually go in and warm up those lungs, so the person can warm from the inside out. So this is a humidifier. So same thing, air goes, or oxygen goes in, it goes down through here and then up. So it picks up a little bit of water. Non-medical hazards are extremely rare, but it can happen. You're dealing with a very high pressure system, so we don't want to make a missile out of the oxygen bottle. It can cause fire to burn a lot more rapid. Medical hazards do take time to develop. Oxygen toxicity or air sac collapse occurs when there's an overload of oxygen. This is why we cannot breathe 100% oxygen for very long. Eye damage may occur because they're relieving pure oxygen over a long period of time. Respiratory depression or arrest can occur when people become reliant on, and you'll learn more about this in your COPD patients. They will want to breathe only when their carbon dioxide levels reach a certain level, and then they'll want to breathe. So if you constantly are feeding oxygen into them, they're not going to have that increase of carbon dioxide, and so they're going to want to stop breathing. There's different devices available. So you're going to do these. This is where the adequate, inadequate. So for mild distress, nasal cannula. For moderate distress, you're going to do a non-rebreather mask up to a BVM. But local protocols, you need to go off of what your medical director says. Non-rebreather mask is the best way to deliver oxygen to breathing patients if they are in distress, because they can be somewhat unconscious and you can give them oxygen. The bag must be inflated. Remember I talked about how the BVM, the bag did not have to be inflated. Well, this one you have to. So non-rebreather means that they can't rebreathe the air. So there's valves that allow their exhaled air to escape, but then they're not going to rebreathe that in. So here we go. Air can go out, but it can't go back in through these things here. This needs to be inflated because this is where all the oxygen in. They're going to breathe more than this tube can manage. This tube is not going to be able to withstand the space in their lungs. So that's why you have to have this reservoir filled. You have to have it full. And again, it's a strap that goes around the head. Nasal cannula provides the lowest concentrations, about 24 to 44%. So it's just a little bit higher than what we breathe in our air. In the movies, you're going to see how they completely mess up how to put a nasal cannula on. It's ridiculous. They put nasal cannulas on everybody, even in like people that have bags on their face, like the BVM and stuff, and it's ridiculous. Or they'll have a nasal cannula on for somebody that's intubated because they don't understand medicine and they just make stuff up. So nasal cannula is a good choice for somebody that is unable to put a mask on because of panic or fear. Nasal cannula, these go into the nose. One there, one there. Partial rebreather mask. There's not many places that actually have a partial rebreather mask. It does not have the one-way valve like the non-rebreather. And so it does allow the patient to rebreathe a little bit of their exhaled air. So it is useful in keeping some of the carbon dioxide levels. Venturi mask, you can actually specify the oxygen concentrations. So you can have it at 100% oxygen delivered, 40% oxygen delivered. It's mainly used on your COPD patients because, like I said before, they depend on a higher level of carbon dioxide in their body for them to want to take a breath in. Here's a Venturi mask. So there's actually a device down here that determines how much oxygen is going to go into the mask itself. Trach is over the stoma or trach tube to provide oxygen. It fits right over the trach. So this here, their trach will be here. So that stoma that's in their throat. I'll let you guys read that again. So high concentration of oxygen should be given to children in distress. If you can't get a mask on them because they're kids and they don't want a big mask on their face, you can do blow-by, which is holding the mask away from their face and allowing the oxygen to pass over the face in the air just right in front of them. Special considerations: facial injuries. It may make putting a mask on very difficult. It may make it to where you have to do a lot of suctioning. There could be obstructions, so make sure that if you're doing compressions or CPR on somebody, every time you do the ventilation, so you're 30 and 2, every time you go to do your 2 breaths, look in there to see if you can see whatever the object is that caused them to choke. Dentures should be left in place unless they are posing an issue. They can be dislodged during an emergency. If you have to remove it, you can remove it, but it's going to make the airway a lot more difficult. Little kids have a much larger tongue because they have a much smaller airway. Their trachea is a lot more soft and flexible. It is not nearly as rigid, so it can't handle the closing of the airway as much with the head tilt. So you have to bring those shoulders, you have to bring the upper body up a little higher. Avoid excessive pressure and volume. We don't want to expand the lungs completely out. You just want to make it to where the chest rises and falls. You need to use pediatric sized masks and cannulas because otherwise it's not going to fit. You need to be aware that you put too much fluid or air in, you're going to end up pushing fluid out of their stomach and right into their airway or right into your face. You guys won't be putting endotracheal tubes in, but you could be putting eye gels or King Airways in. So understanding advanced airway devices, you may be asked to put extra oxygen on the patient. Nobody helps with the burp method anymore, but this is a paramedic putting an endotracheal tube in. Once the paramedic puts it in, they do have to ensure that it's in proper alignment. So they're going to be moving around the patient. They may ask you to breathe faster than typical. So they'll have, because they're going to be listening to lungs and they're not going to wait 5 seconds. They're going to listen and then move to the other side and listen. And then, so you may be asked to squeeze like 3 times in a row. And that's why they're checking for something specific. Very little movement can displace a tube. So anytime you do move the patient, make sure you listen to lung sounds or you remind your paramedic to listen to lung sounds. You want to hold on to that tube, secure that tube while you're pushing with the BVM. You want to make sure that you're not dislodging that tube. Report any changes to your paramedic about any resistance to the ventilations. Every time you shock the patient during CPR, just remove the bag from the tubing and then constantly, let's see. During cardiac arrest, you may have to remove the bag so medication can be put into the tube. It's not as typical now that we have IOs, but it can still happen. Let's see. It's actually really good to put a C-collar on even if there's no trauma to the neck because it will help hold the neck in line and help secure that advanced airway. You'll have to help anchor the tube, which is just basically holding it in place so you don't have to hold it in place with your fingers. All right. Respiratory failure is inadequate breathing. It is insufficient to support life. They're not able to compensate anymore. So you have to put some sort of non-rebreather mask on for them and help increase that tidal volume. Respiratory arrest, they are going to have artificial ventilations. Let's see. Inadequate, you can see by cyanotic, cool and clammy skin, they're short of breath, they have chest pain, severe injuries, displaying an altered mental status. Use PPE when managing an airway, don't do mouth to mouth. Positive pressure ventilations are different from normal breathing, and they can have some negative side effects. And don't drop your oxygen. All right, real quick, another one here, really quick. Let's see. All right, what is CPAP? When do we use it? When we don't use it. Some additional features, comparing it to the BiPAP. Can't do the hands-on, but we will go over some of the summary. So CPAP is continuous positive pressure, airway pressure. So it is blowing oxygen air continuously at a very low pressure into the airway. So I can't use it. I don't like the way it makes my breathing feel. It feels like I'm sticking my head out of a car window and have that high pressure on my mouth and airway all the time. Basically, it helps prevent the alveoli from collapsing. It keeps those balloons inflated for as long as you have the CPAP on. It prevents the collapse of the alveoli. It stabilizes the chest wall, so it has that expansion of the chest. It splints the airway open, so it has that positive pressure, that continuous pressure to keep that airway open. And it stretches the lung and pleura to be able to get more oxygenation in. So steady stream CPAP goes in. It helps to open the airway because you're going to have a constant pressure here to help open that airway. The alveoli, you can see here on the right, the collapsed alveoli, and on the left, a normal alveoli. With that air going in with the CPAP, this collapsed one will actually expand out, and there's more surface area to be able to exchange the oxygen and the carbon dioxide. There's different brands. You'll see most of them in the ambulance have the comfort gel, either comfort gel blue, the comfort gel, there's like different sizes. Most of them don't have like the full face. When people have CPAP for at home, they might have the ones that just goes into the nose, the nasal prongs. They may have the cup that goes over the nose. There's different styles. A lot of them will have the support on the forehead as well as on the rest of the face. Some of the side effects of it, with all that extra pressure, it could have pressure built on the heart, which will decrease the blood flow. So it'll cause a drop in blood pressure. With all that pressure in the lungs, it could actually pop a lung and cause a pneumothorax. With the high pressure in there, if they throw up or they have any fluid in their mouth or airway, it can get pushed into the lungs. So an increased risk of aspiration. And then if the seal is not on there or you have that full face one, it can actually dry out the corneas. So you can see here different pneumothoraxes, a small pneumothorax. This is a large pneumothorax, and then the treatment of it is actually puncturing a hole to release the air so it can get out. Indications of use, dyspnea or air hunger, they have to be alert and able to hold the mask, and they have to be breathing. So they have to have spontaneous respirations, and they have to be able to hold the mask. The numbers that we give here, the 90 systolic, different services may have different numbers, but it's an adequate blood pressure. They have to have a blood pressure that's going to support their mentation. So they can't be hypotensive because they could develop more hypotensive. Common uses, so the 6 P's of dyspnea. We will use this for drowning. It could be from like water in there. You can see water in the lungs. It could be from asthma or COPD, respiratory failure in general. They're not able to breathe on their own. Pulmonary edema, pneumonia, and sleep apnea. It doesn't even have to be an emergency thing. It could be something chronic like sleep apnea. So pulmonary edema, this is an emergency. Lungs will fill with fluid. The surfactant actually keeps the alveoli from collapsing. And so even after, when people are like, oh, I'm fine, they had like a drowning accident and they get out and they think they're fine, they should still go to the hospital. And the reason is because at any point their lungs could collapse, especially with a saltwater drowning over a freshwater drowning. And the reason is, so saltwater, what will happen is the high concentrations of salt, your body will want to move water in to dilute that salt out. And so even hours after you had your drowning incident, you're like, hey, I'm totally fine, whatever, I'm going to go home. Then they're going to have flash pulmonary edema. All of a sudden, water comes flying into the lungs to dilute that salt that's in the lungs, and they end up drowning later. Asthma is a chronic lung disease that narrows the airways. You can see here how it's thickened. It makes it a lot smaller. This is why they have wheezes. If you think of how a whistle is made, you purse your lips together, you make it a lot tighter airway. And so when they're having this constriction, it causes a tighter airway, and it will get like a late musical airway is what they call it, a musical sound. I don't think it's very musically, but it definitely has some sort of whistly sound. Chronic bronchitis. They're going to have more irritated airways. It is a little different than your asthma because it actually has damage to the cilia as opposed to a bronchoconstriction. Chronic bronchitis is bronchitis that lasts longer than 3 months, but within that 2 years in a row. Like, so 3 months, and then a year later, 3 months, they've got some sort of chronic bronchitis. So chronic bronchitis, they're usually overweight. They have a constant like bluish appearance to them. They commonly it's from smoking, so they've done a lot of damage to the bronchioles, and so it's kind of like dried them out. They're not able to be as flexible, and they're reddened. Hypercapnia because they're not able to get rid of carbon dioxide as easily, and they're not getting oxygen in, so they're hypoxic. Gives them that bluish appearance. Their heart's working a lot harder, so their heart will get enlarged. They're having to use accessory muscles to breathe. They're going to have a lot more fluid around the heart, and a lot of fluid. So you can see digital clubbing. You'll have fluid around the at the fingers. Let's see here. COPD, emphysema. So this one here is definitely caused by smoking, and essentially it's just drying out the alveoli. You can see there that the alveoli has been damaged. They're no longer individual sacs. They're like one big nasty goopy sac. Wow. Didn't think I'd ever say those words, but you can see there where it's not going to be very effective. It's not going to be able to fill with oxygen. It's not going to be able to do a good gas exchange. I just need to plug my laptop in. Hold on. Okay, so tissue damage done by the dry smoke. You can see there destruction of the alveoli themselves. Emphysema is your pink puffers. They retain a lot more CO2. So there might be some cyanosis, but really that CO2 just kind of sits there in the alveoli and just kind of hangs out and doesn't do a whole lot of movement back and forth. They're going to be thinner typically with, they call a barrel chest because they're using so much extra accessory muscles to try to breathe. They're trying to force air in and out of those alveoli. So here you can see bronchitis. asthma are very, very similar looking there. But the asthma is reversible. Chronic bronchitis is not reversible. They'll have it for 3 months at a time or even for years. It is manageable. It is not reversible. Contraindications for CPAP. We don't want to use it for penetrating trauma to the chest. We don't want to be expanding the lungs out or the chest wall out anymore if there's some sort of thing that's sticking into the chest. They have to be conscious alert, so they cannot be altered. They can't be hypotensive or going into shock because, again, that'll be making them altered. We don't want them vomiting because that will make the vomit go right back into the lungs. And if they're unable to get a good mask seal, so a big beard or deformity to like the face. We also don't want an upper GI bleed. These people will have likelihood that they're going to vomit, and it could be increasing the pressure on what hole is bleeding, and so that hole can be a lot bigger. BiPAP versus CPAP. So CPAP is continuous pressure. When they inhale, it's the same. When they exhale, it's the same amount of pressure. Needs very little monitoring. You basically put it on and it's good to go. It's a lot cheaper. The BiPAP will actually decrease the pressure during exhalation, so it's easier for the person to exhale, but it's way more expensive. It's usually used in some sort of like hospital in the ICU. So when you go to apply it, you have to explain what's going on to the patient. You have to tell them that this is going to help. You have to tell them it's going to be uncomfortable. You're going to have them hold it. You're going to hold it to their own face. You're going to coach them through it. Okay, breathe in. You feel that? You feel the pressure. It's going to be okay. Hold that here. Once they're calm with it and you've had them hold it for a little bit, then you can secure it. And always have a backup plan. If this fails, if they go unresponsive, there's always BVM. If they're not able to handle this because it causes too much anxiety, you can go with a non-rebreather mask. Always have a backup plan. And you need to call wherever you're taking this patient so they know that they have a CPAP on the way. So then they have to get their CPAP delivery devices ready. All right, so think about 2 contraindications, things that we don't use the CPAP for. Remember the difference between your blue bloater and your pink puffer. Why is he pink? Why is the other one blue? What are 2 reasons that we use the CPAP? Name 2 things. I don't know why it says things ways. Name 2 ways that CPAP works. And can we use it if the patient is not breathing? So that is all I have for you guys today. Hopefully you retain some information there about artificial ventilation and the process in which we breathe, with a little bit of information on CPAP. It really depends on your service provider and if you're able to do advanced airways like the iGel or the King airway, and if you're allowed to use the CPAP. So you guys have a wonderful day and keep going with it.